Welcome back to the Neuroblastoma Parent Global Symposium 2023. My name is Antonia Palmer from Canada. I am a pediatric cancer research advocate. I am the Executive Director of Kindred Foundation and co-founder of Acorn Advocacy for Canadian Childhood Oncology Research Network. And I have the pleasure of moderating this session entitled CAR T Cells in the Clinic. This session is being delivered by Professor Anderson, clinical professor and consultant pediatric oncologist at Great Ormond Street Hospital in the UK, and Professor Quintelli, head of cell and gene therapy for pediatric tumors, IRCCS Bambino Gesù Children's Hospital in Italy. So before I give the floor to Professor Anderson, just want to remind you of the chat function on the right of the screen where you can submit your questions, and they can also be submitted anonymously if you choose. And we'll get to all of the questions after the presentation is finished. So over to you, Professor Anderson, to present on an introduction to CAR T cells.
Excellent. Thank you, Antonia, for the introduction. And there are my slides. So this is working. Okay, so I'm going to give you an introduction to what CAR T cells are and how we make them. I'm going to talk about the clinical trials which have been performed in children with neuroblastoma, what we've learned from the first experience. And I'm going to talk about the future planned trials. But I'm not going to talk about Conchetta's talk after me, because she's going to talk about her own very exciting work from Rome. So we've known about CAR T cells. Well, I've worked on them for 15 years, nearly, actually 13 years. But they kind of became very well known in the community when were really impressive results in leukemia patients. And, the Emily Whitehead shown on the left, she's was a child in Philadelphia and is now 10 years cancer-free. She had end-stage leukemia, but had a very dramatic response to CAR T cells, including some of the side effects, which I'm going to allude to. And one of the reasons they're kind of groundbreaking is because it's a living drug. In other words, it's a drug which doesn't go away. And in her case, a single infusion of T cells was sufficient for long-term cure. And so T cells themselves are, I don't know if my pointer works, but on the left-hand side is showing a slightly dejected T cell. The green thing sticking out of its head is what we call a T cell receptor. That's what normally does the job of recognizing foreign stuff. And the basic technology is to use viruses to infect a patient's own T cells. I'll explain how that's done. The virus goes into the cell. As a result of that, it gets kind of shaken up, and then these red things appear. They are chimeric antigen receptors, and they now target something which the T cell doesn't normally target, and we make it something which is specific to the cancer, and thereby it becomes a cancer-specific therapeutic. So what the chimeric antigen receptor actually looks like is shown in the middle. It's called chimeric because it's a mixture of two things. Without going into too much detail, the bit on the outside in green is actually derived from an antibody, and the bit on the inside is derived from that T cell receptor, which I showed in green in the previous slide. The fried egg on the left is a T cell, and the fried egg on the right is a T cell with the chimeric antigen receptors on its surface. And obviously it shows us only 8. In reality, there's thousands of these on the surface of each CAR T cell. So the slide hasn't come through. There's meant to be a picture of a body in the middle. So imagine there's a picture of a body in the middle, and the blood sample is coming out of it. The idea is within the laboratory, having extracted the blood, we purify the T cells, then use a virus, which we add outside the body to the T cells. They become these sort of activated ones, and they, as shown in the needle at the bottom, they get injected into the patient. So imagine there's a patient there. And obviously then the idea is from the blood, they go into the tumor and kill the tumor because they've been redirected against the tumor. So that's basically how the technology is thought to work. Now, why do we use a virus is because the virus is a clever trick to turn not just the cell we infect, but all its sons and daughters into CAR T cells as well. So shown on the left is a cell with 2 chromosomes. In reality, cells have 26 chromosomes, human cells do. The virus goes in, and the blue stripe you can see represents a new gene inserted into one of the chromosomes. And then next to the right is the cells going cell division, in which, you know, we make 2 copies of everything. And the result is we end up with 2 cells, each of which has got the gene inserted. So each of these 2 cells is now a CAR T cell. So you can see if you inject something like 1 million CAR T cells into a patient and they undergo cell division as a result of dividing in the tumor, then you can end up going from 1 million to 1 billion. And that's how the very strong immune response with CAR T cells actually happens. So this is, again, summarizing all of that. Imagine this is a child rather than a strapping adult. The leukapheresis is the procedure by which we take blood from the patients. We select the T cells, shown in the left, like in a flask, as shown here. We add the virus to them, which is step 2. And then now we've got CAR T cells rather than normal T cells. We expand those in numbers over usually a period of a week or so. Check them that they are the correct sort of cells, which usually involves freezing them down and testing them. And then step 4, we actually give chemotherapy, like a course of chemotherapy, usually over 3 or 4 days prior to the infusion. So 3 or 4 days of chemotherapy, and that's given to prepare the body. It actually decreases the number of white cells in the blood, and it prepares the blood or the body to receive the CAR T cells, and then they get infused, as shown in the green bag, about 24 or 48 hours after finishing the chemotherapy. And at that point, they should expand and go to the tumor and start their work. So that's basically how it works. Now, one of the side effects which happens as a result of injecting the T cells is called cytokine release syndrome. And this is very complex, but essentially it means that you get an immune response similar to an immune response to a vaccine. So if you can think of what it was like having a COVID vaccine, you get, or having COVID itself, you get all your T cells going crazy, producing these chemicals called cytokines. They can cause drop in blood pressure, very high temperatures and things like that, and you basically can feel very ill. And when CAR T cells go out of control following infusion, this is exactly what can happen. And it's not necessarily a bad thing, it's a sign that the immune system has become very active. Now, this slide is very complex, and it's got distorted by going from Mac to PC, but all the basics you need to know are in there. And I'm just going to pick out 2 or 3 things from this, so you don't have to remember all the details. On the left is a structure of what an antibody looks like. And the thing about antibodies, they recognize something on the surface of a cell. So many of you know about anti-GD2 antibodies, which recognize something called GD2 on the surface of neuroblastoma cells. And by a molecular trick, we take the part of the antibody which recognizes GD2, and if my pointer is working, hopefully you can see me pointing on the left-hand side, and put that into the chimeric antigen receptor. And there are 3 flavors of chimeric antigen receptors we call first generation, second generation, third generation. And the difference between them is the number of these, what we call the stimulation parts within the inside of the T cell. And in very simple terms, and this is very complex science, but in simple terms, the first generation gives a weak signal, the second gives a strong, and the third gives a complicated signal. And Conchetta will talk a little bit about third generation later. So it's not necessarily the case that third generation is always better than second generation. It's quite complex. So again, this is going back to the GD2, which is the antibody many people in neuroblastoma field are familiar with, and what GD2 actually looks like, or its chemical structure, is shown on the top left. And an anti-GD2 antibody is incorporated into chimeric antigen receptor. So it's actually the genes of this which we put in the viruses which infect those cells. And when it binds the GD2 on the surface of a neuroblastoma cell, the activation goes through these green bits at the bottom. So because GD2 is present on neuroblastoma but largely missing from normal cells, the T cell will kill a neuroblastoma but not a healthy cell, or at least that's the theory. Now I'm going to just talk through the clinical trials which exist. And first of all, this is the list of trials which are either completed but not yet published. The first 2 are from the United States. So we're waiting to hear the results of those two, in other words. And the second two on this list are trials which have been completed. The bottom one, called 1RG CAR-T, was a trial which I was involved in, Great Ormond Street Hospital. And the one above it was a clinical trial performed in Houston, in Baylor College, Texas Children's Hospital, using a very similar CAR-T cell design to the one which Quintelli is going to talk about in Rome, but with very different results. In terms of forthcoming trials, Quintelli is about to tell you about the third generation anti-GD2 CAR, which has been trialed in Rome and which is still entering patients at least into a managed access program. I'm going to tell you a little bit about a planned trial in Germany, which is going to use an anti-GD2 CAR-T, but a slightly different one because it's what we call an armored CAR. The third one on the list is a CAR-T cell trial, which is planned to open at Great Ormond Street Hospital, probably 2024, and has got some different components to the previous ones. And the fourth one is a trial using a different target antigen, not anti-GD2, but a different cell surface thing called B7H3. And it's a combination trial in which not only the CAR-T cells will be given, but also a drug called lenalidomide. I'll tell you a little bit about those. And these are the open clinical trials in the USA at the moment. One in Texas Children's with colleagues Andres Hexy as the leader. And it's different because rather than using normal T cells, it's using a special type of T cell called NKT cells, but it is open and recruiting. I'll say a little bit about that. And the second one on this list is in Children's Hospital Philadelphia. And again, it's targeting a different antigen. So there's a third one I've mentioned. This one's called GPC2. So it's GPC2 rather than GD2. But in many ways, it's similar to the anti-GD2 CAR-T. So these slides give an idea of there's quite a lot of activity. And I'm just talking about the trials in North America and Europe here. So if you think about how we make CAR-T cells better, without going to all the details in here, most people in the neuroblastoma field know about anti-GD2, but there are these other alternative, what we call targets on the surface of neuroblastoma cells, which in theory you can go for. B7H3 and GPC2 I have mentioned. There are no ALK CARs in clinic or with clinical trial funding at present. And in this slide, I've tried to just emphasize some of the ways of improving this, like changing the type of T cell we put in. I already mentioned the trial in children and Texas Children's using a cell type called NKT cells, and then combinations, like I mentioned, in other words, giving drugs alongside them. So these are the sort of approaches which are likely to lead to increased function of these cells in the future. This is a slide which talks about the trial we did in Great Ormond Street Hospital, and there's just two things to point out in this slide. This is the complexity of how the engineering is all done. But at the bottom, each line represents a patient. And what we're showing here is the number of CAR-T cells found in the blood. And these are the number of days which have elapsed since the time when the T cells were injected. So you can see that in all the patients, the number goes up, but then it goes down quite drastically, which is not what we hoped for and not what we expected when we started doing the clinical trial. And therefore, the clinical responses you see correspond to that. So whilst the tumor disappeared, because the T cells disappeared, or the tumors diminished, they grew again when the T cells disappeared. We only gave one infusion. So we learned a lot, but we learned that it was safe, that it didn't cause severe pain, and that if we can get the T cells to live longer, then there's potential for getting longer term remissions. The third thing to point out is that one individual patient, as shown here, has these drops in blood pressure and very high rises in temperature and inflammation in the blood at the time after following the T cells were injected. So in other words, the side effects are acute and occur within the first few weeks following the infusion. This is one a slide from the trial run by our colleague Andres Hexy in Texas Children's. We're using the NKT cells with the GD2 CAR and some other changes in it, showing that in a few patients they got remissions, although these remissions were not sustained. But that trial is still open, and the next iterations are trying to develop the technology further to improve the outcomes. As I mentioned, our colleagues in Germany have got funding to do a multi-center GD2 clinical trial, GD2 CAR clinical trial. And this one is different because it's a so-called armored CAR. The next slide kind of shows what that means. So a lot of complicated science, but the principle is, but as well as the CAR T cells having the receptor which kills the tumor, when they reach the tumor, they switch on a factory of growth stimulants to stimulate themselves. And so this looks promising in terms of its capacity to overcome the problem of persistence. And this shows that as well as neuroblastoma, they plan to put in some patients with sarcoma and breast cancer, and that it's in these different centers in Germany. And this should open next year because the virus manufacture of this is in place. And this slide shows that it's quite an innovative trial because it's got what we call decentralized manufacturing, which means that rather than the patients moving, the patients are having their T cells made in their local hospital, and the T cells are either being shipped or being made in more than one center. So it's very important, this, because it's going to potentially bring the cost and complexity of these trials down a little bit. As I mentioned, there's another trial at Great Ormond Street called Magneto, which I have omitted to put a slide in. Apologies for that. And then finally, this is a clinical trial which I have co-developed with my colleagues, which is the combination trial. And this is a bit complex, but the idea is we use a drug in combination with a CAR T cell to switch it off. Why do we want to switch it off? Well, it's so that we can give the T cells and then give periods of time when we give the drug or don't give a drug. And when the CAR T cells get switched off, the idea is it gives them a rest and a chance to recover from all the activity. And in theory, this will lead to a more sustained response. That's the reason for doing the combination. And this is funding for clinical trials for 18 patients. There's actually a brain tumor trial as well as a neuroblastoma trial. But we will be making the virus for this starting early next year. And so it won't be ready to open until the end of next year at the earliest. And this is to acknowledge our funders and our collaborators in this international trial. It's Cancer Research UK and Stand Up to Cancer, and also the Medical Research Council who funded it. And this is the design of that planned trial to show that first we find the dose of the T cells, and then we find the dose of the drug which goes with them, called lenalidomide. So in conclusion, I think over the last 10 years, we've found out that these T cells are capable of shrinking tumors. And the next talk will show this in a more dramatic fashion, and I've been able to show it. The early studies, including the ones which many of myself and many of my colleagues have been involved in, have shown that it's important that the T cells have better expansion and survival in order to get sustained clinical responses. And therefore, that's exactly what the field is focused on, improving the engineering so that these cells live much longer. And my fourth point is really just an introduction to my colleague Concetta, who will give the next talk.
Great, thank you so much, Professor Anderson. That was a beautiful description of CAR T cells and an overview of some of the clinical trials that are available. I'd now like to give the floor to Professor Quintelli to present on the GD2 CAR T cell.
Thank you very much, Antonia, for this nice introduction, and good evening to everyone. I'm Concetta Quintelli. I'm working in an Italian institution based in Rome, We are a pediatric hospital, and we have worked several years to optimize the CAR-T product for patients with neuroblastoma. And in my presentation, I will touch the point why we have target GD2 and what is our CAR-T and which were the results for the first 27 patients treated in Italy with this product, and what we usually expect after the infusion of the CAR-T cells, and which are the next step for offering this therapy to a larger number of patients. So thanks to John that has already introduced the target for the CAR-T, that it is GD2 in our case. It is an antigen expressed on the membrane of the neuroblastoma tumor cells. Is composed by a sugar, by a lipid, fat, and it can be targeted by a monoclonal antibody. And this is already a therapy for patients with neuroblastoma. One means that the neuroblastoma express this antigen. It is on the right part of my slides, in which if you want to evaluate the expression of these antigens on the neuroblastoma, you can use a specific technique in the lab, and you can see in brown all the cells that are positive for these antigens. So practically all the cells in the neuroblastoma tumor of our patients express a high level of these antigens. And this is the reason why we decided to target the GD2 for our chimeric antigen receptor therapy. So we have done a preclinical work of 4 years to develop this CAR, and at the end we have a CAR that is a third generation, because there is the inclusion of 2 costimulatory domains in our construct. What this means, he has 2 part of the of our chimeric antigen receptors, able to induce very high activation of the CAR and expansion after the infusion. And this is the structure you can find on the right of the slides. The external part of the yellow is the one that recognizes the tumors, and everything that is below the yellow part are the signaling that help the CAR to be activated and to activate the T cells to kill the tumors. So in our therapies, there is not only the CAR construct, but we also have included a suicide gene. What is a suicide gene? Is a portion of our vector that we include in our T cells to control the side effect of the CAR-T. So if patients has no toxicity, we are not infusing anything after the CAR-T infusion, and the CAR-T are able to recognize the tumors and proliferate. In case of uncontrolled toxicity in our patients, we cannot administer a drug to activate the suicide gene, and this is leading to the elimination of the CAR-T, but the patient is recovered by the toxicity. I'm very sorry, but it's not the final presentation. I'm so sorry about. So it was a video showing how it's possible to expand. Sorry, give me 1 second, and I will share again the presentation. So sorry about, because. Can I show my second slide? He does not let me to share. Again, I'm so sorry about. He said that I cannot share again. Okay. So we started our clinical trial on 2018, and in particular, we opened our trial for patients with high-risk neuroblastoma, so patients that already in diagnosis they were a metastatic disease, and they were refractory or resistant to other therapies. And the trial was open on the beginning only on neuroblastoma patients, but the results were very important for the field of solid tumors. At the end, we decided to include also patients with different solid tumors, but in this presentation, I have summarized the results only for the neuroblastoma patients. So the inclusion were the criteria for inclusion were patients up to 25 years and patients with high-risk neuroblastoma, and also patients that after the first line there were no evidence of disease, and they could be included in this trial only in phase 2. So we decided to design the trial to infuse the first dose of 3 million of cells per kilograms. And we decided to do that considering all the other clinical trials were on for CAR-GD2, and we considered safe this dose for our patients and to escalate to 10 million in case of no toxicity. As Jonah has also said to you before, the patients need to be lymphodepleted before to receive the CAR-T. So it's a chemo that we give to our patients, and this is associated with a better expansion of the CAR-T after the infusion. And then the patients have 2 days of rest and then the infusion of the CAR-T. So which are the steps in the timeline when the patients are enrolled in the trials? The first 5 or 7 days is depending of how many tests the patients need to have. We decided the eligibility for the inclusion and also to be able to collect the T cells in the apheresis of the patients. They usually are for 2 days of hospitalization, in particular if the patient has not the access for the catheter to collect the T cells. And then in the second day, we collect the T cells, and then the patients can go home. So usually, because our patients relapsed or refractory, usually we use the bridging therapy. So we use chemotherapy in our patients to keep the tumors as low burden. And the patients need to wait at least 4 weeks then to receive the CAR-T, because we usually take 3 weeks for the preparation of this drug. And when the drug is able to be provided to the patients, then we apply the lymphodepletion chemotherapy for 5 days, as before said, and then we infuse CAR-T cells. So basically, the infusion of CAR-T cells can last 15 minutes if the patient is very small, depending on how many cells we need to infuse, but no more than 1 hour will take the whole infusion of the bags. What this means that we will start to produce the cells. So And as you can see on the left, we have a clean room for the manufacturing of the cells. So yeah, if you think that any drugs need to be sterilized before to be given to the patients, usually for standard drugs. In our case, since our live cells, they cannot be sterilized, and then we need to comply that all the environment in which they are produced needs to be completely clean. And as you can see on the left, the people working in the room for the production are completely covered for the hands, the hat, the glasses, everything. So nothing from outside can be in contact with the cells of the patients during the manipulation of them. So in our clinical trial, we have treated 27 patients with the upper age of 25. And what happened to the patients after the infusion? As John also said to you, on the beginning it's not possible to detect CAR T in the blood of the patients. So you need to wait. And this is a live drug. So when they infuse it and the T cells are encountering the tumors, they start to proliferate massively, proliferation of these cells. And then you start to detect the CAR T in the peripheral blood of the patients. So usually this is also associated with the fever, because when the CAR T recognizes the tumor, they produce several cytokines that induce inflammation and then fever in our patients. So usually fever for us is a good sign that CAR T are starting to act in our patients. But of course, this inflammation needs to be taken under control because it can be mild, so only fever, headache, rash will be fine for patients, but they can become severe, and then the patients need to be treated to control the side effects. Which were the results in our patients? So the toxicity were in the majority of cases very mild, and you can see on the left. On the right are the results from the clinical trial. The majority of the patients had a complete response, the partial response, or stable disease for very prolonged time. In particular, the best response we obtained in patients with a low tumor burden. In particular, there were patients that were treated very early after the first relapse with the low tumor burden, and it was associated with the majority of them with a complete response. So the next steps for us will be to try to expand the use of these specific products in other regions in Europe, and we are in collaboration with other hospitals in Europe to launch a phase 3 clinical trial for the use of CAR-GD2 in patients in early relapse. And we're also studying preclinically how to increase the response rate in our patients, and also other cancer indications in which to use CAR-GD2 T cells. So in conclusion, I have shown to you that CAR-GD2 can be an option for patients with neuroblastoma. And in the clinical trial, we had a sustained disease eradication, especially for patients with low tumor burden. And we are collaborating with other hospitals that have interest to treat their patients with our product. This is something no easy because this product is made by us, that we are a hospital and academic institution. We are not a company. And so we are supporting ourselves with research grant and charity for the clinical trial and the patient's treatment. And then for us, it's important the researchers, clinicians, regulators, and private company will sit together and understand how to enlarge the use of CAR T cells for all the patients that can need that. And I cannot end my presentation thanking Professor Quintelli, that was the PI of our clinical trials, all the young people working for the production of CAR T cells for solid tumors and hematologic indications, and so the Italian Foundation for Neuroblastoma that has funded our preclinical research, and all the charity institutions that are supporting our research. Thank you.
Thank you so much, Dr. Quintelli, Professor Quintelli. That was absolutely beautiful and just incredible work that's been done in this trial. We already have a number of questions which have come in, and so we'll start with the very first one. So which antigens are the most promising targets for CAR T in neuroblastoma?
Shall I talk about that, Concerta? I think GD2 is the most promising because it's got the best clinical results. One of the reasons there's a lot of interest in B7-H3 is because it's applicable to a lot of other childhood high-risk cancers. And so they're the two leading ones, I would say, internationally. There's another question about GPC2 later on. And one of the reasons there's a lot of interest in that is because it's got very low expression outside of neuroblastoma. But it's not been tested, well, it's being tested clinically, but we haven't got any results yet. However, in the preclinical work, there seems to be an ability of the tumor cells to switch off GPC2 to escape it. Whether that happens in patients or not, we don't know yet, but it's just a bit of a question mark against it.
Okay, thank you. Dr. Quintelli, is there anything to add to that one?
No, I agree with John. GD2 is the most used right now for clinical trials, but there are really many work for the preclinic try to find alternative, but also a synergic target for neuroblastoma. One day we can imagine to deeply characterize the patient's tumor cells and then decide which is the best target. So right now we don't have the answer for these questions, but maybe working with many targets together will be better to control the tumor.
Thank you. Professor Quintelli, I'll give this question to you. So some patients require more than one CAR T cell infusion. So what determines the persistence of the CAR T in the body?
Very good question. So we use the double infusion with patients that didn't show a complete response to the first infusion. The decision to infuse the second dose to the patients, it was not led by the evaluation of the persistence. So sometimes the patients had still persistence after the first infusion, but not complete response. And this is the reason why we decided to infuse with the second dose. What is determining the persistence of our CAR T cells? I really don't have the answer for that. We are trying to understand if it's the patient's the tumor microenvironment in the patients or features of the CAR T. They are different, the end between one patient and the other to make the difference. But right now there is not a clear answer to these questions.
Okay, thank you. Professor Anderson, I think I'll direct this one to you. So we are seeing a lot of research happening around CAR T and around solid tumors and neuroblastoma. It's happening worldwide. How are researchers making sure that we're working together, sharing information, adapting research as new discoveries are being made so that we can move this research forward as quickly as possible?
It's a terrific question. I mean, I do think there's a huge amount of collaboration. We talk to each other a lot. There's a lot of shared grants, and there's actually quite a lot of coordination as well, especially within Europe, I think. I mean, Europe is a bit behind the United States in the technology, but in the last 3 or 4 years in pediatrics, we've had very good strategic meetings, in particular with ITCC, which is Innovative Treatment of Childhood Cancers, where we've worked, especially, you know, a good example is the German collaborative group, but also we've written a lot of grants, and the you know, the trial, two trials I'm developing are joint with the Netherlands, which will be our first CAR T studies in the Netherlands. And as Concetta mentioned, you know, there's, I think, 8 countries are hoping to take part in the phase 3 evaluation in a very coordinated way. So, you know, I can't really give a quick answer to that question because it's difficult. But the kind of the flip side of that is that the trials themselves are incredibly expensive. And so you need big research grants to run them, which can only be achieved by competition against other competing people. And it's not kind of possible to have such a coordinated approach that everybody does something different. But it's kind of worked out well. For example, the 4 or 5 trials which I mentioned are all asking different questions, whether it's about combination with a drug, or using these factories so the T cells make their own, or testing whether the Rome GD2 3rd generation is going to be as effective when tested in a much larger number of patients. So there's a real richness and diversity of questions being asked in these different trials, which I think is really good, very good for the field, very good for the patients.
Great. Is there, just as a follow-on question to that, is there anything that we can do as patient advocates, as charities, as caregivers, to be able to assist with ensuring that there is collaboration so that different questions continue to be asked and there isn't a duplication of effort where duplication isn't needed?
Concetta, do you want to comment on that?
So we have really great collaboration with the foundation and charities. So for us, in our experience, they were really helping researchers to be together, especially providing support to a collaborative research. So like a collaborative grant, putting together researcher nationally or internationally, and this really help different teams working together.
Professor Quintelli, I believe you've answered this in your presentation, but I will ask it just in case there's any other information to add. But you've mentioned that the trial will be expanded. Will there be other locations, other European countries that will be able to access the therapy given the great results?
So also John has mentioned, John is participating to this great effort with the intent to launch a phase 3 clinical trials with 8 different countries in Europe. And so we are really working hardly to understand how this can be possible also in a very short timeline, because our clinical trial, it just ends. So the phase 2 is no more opened, and we need to understand which is the right frame in which to restart to the treatment of patients. So right now, at the national level, we are treating patients in hospital exemption. That is like a regulatory wise to in which we can provide the drugs, but in this way we cannot treat the patients that are coming from outside, because it's only for national patients, so the drug cannot be shipped outside our country to be used in another hospital. It is an European regulation that we have. So the only way to treat the patients in other hospitals to launch a phase 3 clinical trial. As John said, the economic part is not easy, but it's not the only thing that we need to overcome to be able to start in 2024 a phase 3 clinical trial, because is a large effort for the manufacturing, because will be a high number of patients, and also a large effort because each country has a different regulation, and so we are trying to keep everyone on the same line to include the majority of the country that will be possible. And just as an information, there are also Canadian hospital that wants to be included, but we don't know yet if it's possible to do something like that and large for including also a hospital that are outside Europe. And so we're also contacted by Australian hospital and colleagues that they asked to be included in the trials, but again, larger is the number and the country, more difficult will be to start. So we will try to keep the starting of the phase 3 as easy as possible to start right away. And when at least the European country will be provided by the drug to treat the European patients, then we will start to think how to enlarge outside Europe.
Thank you. We have lots of questions, but not a lot of time left. So I'll ask this one. What type of patients respond better to CAR T cells? Soft tissue, bone marrow, bone?
So in our trial, the complete response they were for all the patients that had the bone metastasis. All the bone metastases were completely eliminated, eradicated, and without relapse. So the location that were most difficult to eradicate were the lymph nodes. Lymph nodes was very difficult. Maybe the microenvironment of that location were negatively modulating CAR T. This was we found.
Okay, thank you. Have you found that there's any difference between older and younger children and how difficult it is for them to go through CAR T cell therapy?
I don't know, John, if you want to answer, or I can.
I'm not aware of any difference. No. I mean, one of the interesting questions is whether the quality of the T cells from of a patient is different. And there is some evidence that younger children and those who have had less previous treatment will have more naive and more active T cells. I don't think it's proven, but there's certainly evidence pointing that way.
We also in our trial, we didn't find any correlation between age and response.
Okay, thank you. I will ask, so the next question that we have here is how easy is it to prepare an off-the-shelf product that doesn't need the patient's cells to be manufactured? Is that possible?
Shall I talk to that one? Yeah, I mean, a lot of people are very interested in this and of course working on it. I think the answer is it's very difficult to make it because it has to be made in such a way that it won't be rejected and that it won't attack the patient's healthy tissue. So that requires what we call engineering. And in acute myeloid leukemia, this has been done to make these off the shelf and shown to be safe. But the work required is high. And in that context, it was used just as what we call a bridge to transplant rather than as a long-lived cell. We're yet to see really convincing evidence that off-the-shelf products can live long-term. There's bits of evidence emerging from some adult studies using different types of cells, but it's of great interest to many people in the field who are working on it. I mean, Conchetta has actual experience of using donor-derived. I don't know if you want to talk about that, Concetta, a little bit.
Thank you. As not an off-the-shelf product, because
Exactly.
it was a product made specifically for the patients, was a donor-derived, as John said. So we didn't start, for some patients, we had difficulty to harvest enough T cells for the manufacturing, because patients after chemo, they were heavily lymphodepleted. So no possibility to have the manufacturing from the patients itself. So we decided to start the manufacturing from identical donors. And we have infused 5 patients up today with allogenic CAR GD2 product, neuroblastoma, and the product was safe. Patients did not develop GVHD, and patients that did not respond to the autologous product, they had a response to the allogenic one. So allogenic product can be considered in patients that are they cannot be eligible for autologous product, but we need to start a clinical trial to collect the data for efficacy and safety for a larger number of patients, of course.
Thank you. I'm told we have a couple more minutes, so maybe I'll ask maybe 2 more questions. So would a higher bone marrow disease burden correlate with a higher risk for CRS?
I don't know. Do you know?
I didn't get, so if a high bone marrow infiltration, it was correlated with the higher CRS?
Higher risk for CRS, yes.
High risk of CRS. So the higher CRS that we had were patients with a large tumor burden and bone marrow infiltration. It was not only bone marrow infiltration, but they had also very large tumor mass. So I cannot know if it was for the bone marrow infiltration or for the other location, but it is true that larger is the tumor burden, higher is the risk of CRS.
Yeah, I mean, that's exactly our observation as well. But whether it's bone marrow, I'm not sure. I don't think there's enough patients to know.
Well, thank you both so much. We'll stop here. There are lots of questions and lots of interest in CAR T-cell therapy for neuroblastoma. So thank you to you both. Thank you to everyone watching. Thank you for all the questions. Please remember, if you have missed a session, it will be available to watch on demand here on the event platform. And up next, right here on Stream 1, we will have the closing session. Well, we'll hear a roundup from Dr. Morgenstern, a message of hope from parents Matt and Colleen White, and watch a beautiful video montage dedicated to all the children and young people affected by neuroblastoma around the world. Thank you so much.